Hello and welcome to Podiatry Practice Mastery. My name is Don Pelto and I have Ben Pearl here. Welcome, Ben.
Hey, Don, thanks for having me on your podcast. It's a real honor. You're actually the first person that's interviewed me
Oh, really?
for one of
Because
these
you have
podcasts.
your
Yeah.
own podcast, and if people are interested, you can just share it right now. How can they learn about your podcast?
So I do a segment called Fit Foot You, and I've had a few luminaries in our field: Dave Armstrong, some other biomechanics gurus, Ben Onig, just different people. A lot of them associated with the American Academy of Podiatric Sports Medicine, which I'm a fellow of.
Okay.
And just gives them a chance to talk about what they're passionate about. If they have a particular book they're promoting, Doug Ritchie promoted his pathomechanics book that he authored recently. So it's a nice way. And I learned so much, as I'm sure you do from your guests as well.
Yeah, and I'll put a little link underneath the show in the show notes for the link to that podcast for everyone. So today, Ben, you're expert at sports medicine, and you're kind of transforming the industry in terms of your protocols and even some of your inventions. So tell me what you're passionate about and what excites you right now about your practice, about business.
Well, so I try to relate to my patients through my own participation in sport. My background is I was a walk-on at Indiana University for track, quickly got cut as I realized I was just not up to the standard of Big Ten Olympic caliber athletics. Change over to bike racing, but then continued my athletic pursuits after well, actually in podiatry school with soccer, and then also skiing. I was a professional ski instructor for a period of time. So all those things have given me a more intimate understanding of the limitations of doing things, orthotics, interventions within the equipment that you're limited to with a ski boot and or cleats, where you have tighter fits than, let's say, running shoes. And my passion is to keep those athletes and myself active with their sport. So that led me to trying to come up with solutions that would be, I guess, expeditious and then also convenient for patients to apply. And then we can talk when we're ready about some of the splints and things that I've developed to try to help out with certain conditions.
Yeah, something that's let's talk about sports medicine. Like what's really popular right now is regenerative. Maybe we could start with regenerative medicine, how you use it in your practice, how it's been for you, and how that really, I think you'd have a word, fast turn, like increases their results quicker. So tell me about that.
Right. So that therapeutic moment when patients come into the practice and have been sort of just not really progressing with, let's say, the typical treatment protocol with, let's say, plantar fasciitis, doing a night splint, maybe an over-the-counter orthotic while they're waiting for their custom orthotic. So I've tried to come up with some algorithms that will help them progress faster and not just if I guess there's controversy about what cortisone is actually doing, but with regenerative medicine, we have the opportunity to actually, quote, heal the fascia and or the tendon. So I was an early adopter to things like amnion in particular, because the price point for that versus something like platelet-rich plasma is lower in that you don't have to have as many injections theoretically, sometimes just one, maybe two, and that's all you need. And I do it in a fashion of where it's at ambient temperature, and there's been various preparations. We had micronized preparations available for a while. The MiMedx company actually had one that they are no longer able to do for sports medicine purposes, but now I use a lot of the fluid flow options that are available at ambient temperature. So when they're not cryopreserved, there's less cost there because of the shipping costs associated with cryopreservation. But they work very well. I know you use them in your practice, and I use these amnion injections to the actual point target tissue, guided with ultrasound, so I can see where the fascia defect is, or the tendon defect, or the plantar tear, if it's not a full tear and doesn't need surgical repair. Apply the injection to that area. I've done it to my own Achilles tendon, and that made me a real believer.
Okay.
for the field of regenerative medicine.
Now, Ben, where does it fall into your protocol? Let's say traditional plantar fasciitis, you try anti-inflammatories, icing, night splint, stretching, PT. Does it come in like visit 1 or 2, or do you wait, and how do you bring it up in terms of to the patients?
Yeah, if I have a high level athlete that's trying to return sooner rather than later, I'll bring it up sooner. If I have an everyday person that's just trying to maintain fitness, I'll go through more of the traditional longer period of protocols, might even be 3 visits before we enter, a cash pay situation with doing a regenerative medicine option. And then the other one that, as you know, that can be done in tandem is shockwave therapy, or I use the
Yeah.
extracorporeal pulse activation therapy. So there's various shockwave machines. I happen to have one of the EPAT units
Me too.
by Stores, but I think Zimmer and some of the other companies do fine ones as well.
So I usually bring it up, and I like to hear how you explain it. I basically say that I think the tissue becomes chronically injured. There's not the best blood flow. I'll show them on the ultrasound. I'll show them maybe the area of effusion, and I'll say, we do the traditional things. I think cortisone, I kind of say it's harmful, I think, if you use too much of it, and it's not going to really heal it. The way to heal it is with this. I usually do, if I'm doing combo radial and focused, I'll do 200 a session. I'll do between 3 and 6 sessions. And then for our amnio, it's a little bit expensive. It's like 1,500. So that's probably why I'm doing less of it. So that's kind of how we do it. Is that how you kind of explain it and do it too?
In that kind of nomenclature, I will mention, for instance, terms like that we can jumpstart the healing process, that we're adding growth factors to the area. And I kind of liken it to dumb it down a little bit, to fertilizer for your grass, for your lawn. So that way it's something very clear that they can kind of hang their hat on. I also mentioned to them with shockwave in particular, that we are getting more blood flow to the area, and they can actually see that rosy appearance of the tendon area after we do a shockwave session, so that they can clearly feel that there is something happening in terms of blood flow.
So you show them on their skin, the redness, or on the ultrasound with the
on their skin after we do an EPAT treatment.
That's cool.
The other thing that I've had happen too in terms of mobilization of edema is that, let's say I have an ankle sprain and I'm applying the shockwave to the lateral aspect of the ankle. I will sometimes be able to see, not always, but sometimes be able to see that right after we do the treatment, and sometimes I'll take a picture if it's really swollen, that the after picture, it has mobilized some of that edema out of the interstitial tissue and into the leg and away from the injured area. So I do believe you get a little bit of that in some cases, especially when the skin is very tented, that you can actually push the interstitial fluid out of the injured area.
Now, Ben, how often are you doing just the amnio with shockwave, or just shockwave alone? Are you always doing it in conjunction, or a lot of times separate?
I think because of patient cost, I usually will defer to one or the other first. There are practices whose approach is to kind of throw the kitchen sink at something in terms of regenerative. And I respect that, but I think from a patient standpoint, sometimes they want to sort of have an idea of what is working. And I like to give things a fair shake, let's say 3 shockwave treatments, at least as a baseline, to be able to sort of codify what sort of effect we had with that protocol.
Wow. Yeah, I'm in the same agreement. That's great. Cool. Good. I think we covered those types of regenerative things. You also do a lot of orthotics and things like that, printing orthotics, biomechanics. So tell me about some of those game-changing things that you're seeing in your practice that are kind of innovative.
Well, the big game changer that I had this past year, I try to add one thing to my practice each year. I think that's like a good practice goal, but to spend time with it so you're not adding too many things at once. The big changer for me, and I'm going to try to tilt the camera so you can see it in the podcast, is that we've added 3D printing as a office-based and not just using a central lab. So there's 2 ways that, of course, that we can scan. We can scan where we send that image, and I'll show you an example of something that we have here.
And
We're
this-
actually printing now, so
Wow.
I thought maybe it might be too noisy, but it's not.
And this is your waiting room, right?
Yeah, this is right in the waiting room.
Wow.
I don't know if you've got a good image of the
Yeah,
actual image on the background on the computer, but that is the image of the orthotic that is being printed on the printer itself.
Wow, that's a
And
cool
so
factor.
Yeah, the cool factor is up towards the ceiling with this, and I have to thank my colleague Dr. Jay Spector, who's got his practice is at Atlanta Podiatry, Atlanta Sports Medicine down south, and he encouraged me to pursue this. And I think initially, when I first saw these programs, they weren't as sophisticated. They didn't have as many features. Dr. Paul Langer has worked with the company that I work with, which happens to be OLT. There's several good 3D print companies out there, but they take the input that we have as practitioners into consideration. So if we say we want to have a Kirby Sky, they put it into the program. If they say, if I talk to them and say, hey, I'd like to do something a little bit lower, we can then make, like, this is for instance, a soccer cleat where you can see that it's dropped lower.
Mhm.
We can make this a full length device if we choose so. And by the advantage there is then we can take a top cover material. This happens to be Adidas Boost EVA, and we can apply that to a full length without having to a full length under device without having to apply a bottom cover. So you have a little bit of stiffness there, so it won't fold up in the shoe when you adhere the top cover.
Wow, that's your patients. That now, can they see you and print it that day and pick it up, or does it take 24 hours, or how does that work?
Sure. We've done situations. I had an ex Indianapolis cult that came in that knows me, and he came into town from Carolina, and so I did it that weekend and printed it that day. Left the office. He was like a size 13 foot. It took about 3 hours to print that full length device, each one. So left the office, came back, took the one off, and then printed the second. In a pediatric situation, you can actually arrange the locus so that you can print both at the same time because it's small enough on that platform that you can print both. And from the standpoint of what you mentioned, the cool factor, I kind of liken it, and this was, again, my colleague Jay Spector's idea, to have the print device in the waiting room. So it's almost like it has this Willy Wonka and the Chocolate Factory effect where they see it and it becomes, they own it a little bit more because it's not something more
I'm sending it out,
tangential.
right? I'm sending it out to a lab and they're going to send it back to me. It's like they can see it being produced. It's it's the IKEA effect. When you put your furniture together from IKEA, it has greater value than if you just bought it.
Right. And they feel like they're getting direct input. I've had some people that are into 3D printing and they say, oh, can we make this a little bit lower? And once you have that image, you can just alter the prescription. That image is yours. Usually there's a small download fee that they do some of the image processing to jive it with the device and the foot model that you've scanned. And then you have the final adjustments that you make with heel depth, amount of varus that you want in the heel, all those features.
Now, do you do all of yours that way, or do you still send out some?
I still send out occasionally, although we're probably doing about 95%. And I didn't think it would be that high, but the acceptance rate has been great. And really where the conversation goes in terms of the compliance and what I call sort of the therapeutic moment is when and this just happened the other day. I had a dad come in, Seaver's disease, typical thing where, heel lift is one of the main things with Seaver's disease, just changing the angulation, but getting something underfoot with arch support is important too. So when the family realized that they can get this thing printed out in 2 days, they were all in. So we've now removed this sort of the pandemic effect where
the 3-week delay,
depending on your lab, if they've had to do shift work where they've had employees out and protocols, where now you're getting shipping delays, where it might be upwards of, 2 to 3 months, what used to take you 6 weeks. Now you're getting them in 48 hours. And I think that the patient acceptance, the satisfaction rate really has improved, to that effect.
It's Ben, it's the Amazon effect. We want it in 2 days delivered. And if you're doing that, the guy next door is going to take 4 weeks to get an orthotic. They're all going to come see you. That's amazing.
So, and I think that it builds on itself, because eventually they'll remember that. And like, when you do good service, you'll get referrals for it as well.
But like, I don't want to deal with, like, do you glue the top covers? Like, are you doing all those yourself, or do you have staff trained?
You have the option of still using a central lab. And so and to your point, and what I decided to do is to say, look, this thing is almost like a thermal cork. It bends, but yet it's not like something they're going to get at the CVS. It's got some rigidity. You can actually, and I didn't mention this, you can change the durometer, the stiffness of the product. They have 2 different spools that they can send you.
Yep. Mm-hmm.
And at any rate, you also have an array that you can make it more of a grid or less of a grid in terms of the density. And so with that said, a lot of times, because these are so washable and so forth, and they're comfortable to wear, I'm not doing top covers for about 60 to 75% of them. So if they've had forefoot lesions and so forth, you want to have that top cover to make your U pad built in. And so, yes, that does take extra time. And we have kind of a price tier that we do for top cover, as opposed to just the 3/4 length orthosis.
That's awesome, Ben. That's awesome. What other cool things are, like, game changers are in your practice? You're an inventor. You've invented some other stuff, or whatever you want to talk about. This is great.
So one of the things that I do as sort of an add-on is I've used some of these brace layer systems. We're all familiar with something, here's an example of one.
A compression sleeve, right?
Yeah, this is for like, and I don't just use it for plantar fasciitis. I'll use it for peroneal tendonitis, posterior tib tendonitis, Seaver's disease, as I mentioned before. It's been a big thing just to have that sort of kinesthetic awareness and sort of counter pressure against something that's aching in your foot. So I feel like we're getting something sort of swaddling soft tissue pocket, almost like a first aid brace, the old compression, Rice elevation. And by muting those oscillations, I think we're getting a little bit of a therapeutic benefit. Mm-hmm. Yes, it's not the same as a rigid brace, but it's a lot more compliant for people to wear. They can slip it on in 10 seconds. They're not dealing with tape that's unraveling or more difficult to apply. So I don't have anything against using taping in my practice. I use it sometimes in conjunction with, but this is something that a patient can use consistently. I took that concept with a problem that I think we all see in our practices with hallux limitus and turf toe, and decided, why not, for those that can't tolerate the standard carbon plate, maybe it's a little bit too much of a dead stop as you're propulsing over that carbon plate in like a soccer cleat. And I've had that related to me, and I've experienced that myself with the turf toe injury that I had recently. I decided to add a semi-flexible polyurethane splint, and I don't know if you can see this well. Yeah, I can see it
perfect. Yep.
At the bottom of a mitten type thing that you almost like a lobster claw thing that you put on your foot. And so what I found is, although it doesn't have the stiffness of a carbon plate, it still slows down that propulsive momentum and that torque, and will effectively take a little bit of that pressure, to the point where I've had patients say as soon as they've started wearing it, it takes about 30-35% of the pain away. I think what's also valuable about this in-office dispensing with these brace sleeve systems is that you get immediate feedback. So I can have the patient wear it. They can try it. If it's a little bit too tight, we can upsize to a different SKU, a larger SKU. Or if they feel like there's no benefit whatsoever, I don't try to always convince them that, you have to have hours of use. I don't really want to push people into something that they're not comfortable with. So in some cases, if I have the thought that more time will help, I'll mention that it might. But it's always a no-brainer when they have immediate relief, whether it be in part placebo effect, or whether they're, in most cases, in my mind, whether something's actually happening kinesthetically with that brace sleeve system.
I'm going to take that's awesome. One thing that I've learned from my partner, he does a lot of more sports med too. I didn't realize this. People come in plantar fasciitis. A lot of times we'll just do a MB4, a foam roller ball on the back of their calf, roll it out for 30 seconds or a minute. Then they walk and they're in a lot less pain. Everyone's walking out with foam rollers or balls because it's one of those things it's like printing an orthotic. Like they can participate in their care. They see it works and it works great for them. That's awesome.
We do the same thing with that. And we also have added, have you seen like the nylon stretch bands that have the different handholds?
Yeah.
I can have my staff grab one for a visual. Do you want
Okay.
to grab me one of those, Joy, one of those stretch bands if we have one? But the idea being, and I interviewed a guy that was a steeplechase. He was all but made the Olympic team. He was like a 100th of a second, 2 trials in a row. So he never made the actual Olympic team, but he was on the Olympic level team trying to make the Olympics.
Wow.
But at any rate, he's a masseur now, and he's worked with some shoe companies, and he's got a great stretch routine. So I did a podcast with him, and and you can use just a standard nylon rope, and I always tell patients this too, but this just has the advantage of being able to have various hold points.
Yeah, kind of like a TRX band.
Your foot around it. This is called the stretch out strap, and it comes with a little guidebook. But I actually have my patients, while I'm, let's say, doing a block in the other room for an ingrown nail, watch a 2-minute segment of this YouTube video with Tommy, and that's on my FitFoot and so they feel like they're actually participating. And if they like it, great. They've already seen a little bit and can ask me questions about, did I do this hamstring stretch or this glute stretch appropriately, or this glute strengthening? Because you're, holding the dead weight of your leg, you're getting a little bit of strengthening in there, as well as a stretch with some of these protocols. So they love it. They feel like, oh, not only is my podiatrist, giving me a treatment with orthotics or a splint, but he is taking an active physical role in making sure that I'm comfortable doing these home exercises, in the comfort of my home.
Hey, so Ben, I want to, you've been doing this longer than I am, just because you have more gray hair than I do. But one thing I want to ask, I get overwhelmed sometimes, because when plantar fasciitis, we have so many things to offer our patients, and sometimes you don't want to overwhelm them. And so, like, in terms of your how you work in your mind, in terms of, do you explain the compression sleeve the first visit, orthotics the third visit, or do you do it all the first visit? How do you do that, and how do you explain those to the patients, like the compression sleeve and the orthotics? What's your little can spiel?
Yeah. So great point. With orthotics, we know that even with my 3D print, they're not going to get them that day. So we want immediate relief, whether it be a strapping. And I get so much relief, and because of time pressure, with something like, these FS6 sleeves as an example.
So versus strapping.
That just becomes an add-on, and while they're waiting for the orthotic to use. So and the price point, I don't even make people get the pair. If they just want to get one for the foot, we break them up. They're in a wrap anyway. So why require people if they don't want to get two? Some people feel like, oh, you can have the other and just sell them as a set, as a backup, or while one is being drying out, because there is some care required. As far as things like the amnion and those things, those are reserved. I might mention them, especially if I have a high level athlete that has a marathon that they're we're trying to sort of thread the needle in terms of that time pressure to get to the event. But if a patient has time on their side, I'll do the traditional things like the night splint, and that's so hit or miss. I've had patients where we've done the traditional night splints, and or the Strasbourg sock as an alternative if insurance doesn't cover and they want a lower price point. And sometimes I like the idea of pulling the toes back and not just getting the equinus part with the ankle. So I think that there might be some utility with that aspect of the Strasbourg sock, where you're getting that fascial stretch as well. But the patient feedback and results on those is so variable. Some people will do very well with it,
And
and
some
some
their
don't.
toes going numb and they
Right.
can't handle it. Yeah.
Right. And some people tell me they can't handle the idea of wearing a night splint at night. So I say, well, if you can wear it an hour or two a day, that's better than nothing, you know,
Yeah.
while you're seated doing your activities. So I think that, you know, the short answer to your question is I am basically sizing up the need to return to activity. How pressing is that for them? I look also at, obviously, we all have to look at what's covered and what's not covered for the patients to make their decision on based on that. And then what I think is going to get them move the needle the fastest for their situation.
Now, where you live, are orthotics covered by insurance?
We happen to be in the Federal Blue Cross area because I'm within the Capital Beltway of the DC area. I'm here in Arlington, Virginia. So we have the advantage that a lot of our government workers do have coverage for custom orthotics. So that is a big advantage for, we just had a youngster today that it was just a 30% coinsurance. So essentially like it's a $90 proposition for them, which is hardly much more than an OTC.
So then you're doing it first, orthotics, you're doing first visit then.
A lot of times I will.
It's covered and because that's my thought. If everyone got them for free, everyone would have orthotics. But you know, I'm in Massachusetts. Blue Cross doesn't cover, no one covers it, or very few cover. And so it's when to bring it up. I think if it were covered, everyone, I would bring it up day one. But I think, you know, that's what you can do. That's good to know. I forgot about that portion.
And then I still have a small amount, although I do them much less, because let's say I have, you know, a school teacher that's, you know, struggling. I'll sometimes, you know, as we sometimes will do, we'll try to help somebody out. And, you know, if it's a cash pay proposition and we know that they're working hard, you know, we've all done things where we can give people a little break here and there. And with this thing, this device that I make in my office, the cost of, you know, spooling out, and it's not nylon, but it's a material similar to nylon. The cost of that is about $13. So we have our scan processing fee, which is $15 a pair, and that's a one-time fee. So basically for about $28, or you're getting your orthotic, which is probably a little less than half now for most labs. So we have a lot more control of the price point now with what we can do with the orthotics, if we really feel it's necessary and want to give them the option of a custom orthotic.
That's awesome, Ben. Well, we've covered like a lot here today. Thank you for your time. As we're finishing up, is there any things that you'd like people to look at or resources that you want to share? I'll put them in the discussion afterwards.
Yeah, I think I'm especially think that it's helpful both for patients and practitioners of some of the Fit Foot use segments where I've again interviewed people like Doug Ritchie, and he's got so much information that he condensed in his book on the twisted foot. I mean, I start looking at feet now in a different manner than even in school when we were inundated with you know, lower extremity anatomy by some of the nuances of the development of the foot and what's happening pathomechanics wise. So I would highly recommend some of those lectures. And then I think just for the sports minded practitioners, it's good to hear athletes too, because I interview athletes from their standpoint. So I with my podcast, I try to not only interview practitioners, but people that are participants in sport. So you get a different perspective from that. And take a look at some of the options that are available, whether it be 3D printing. I think that would be helpful for a lot of practices. And then some of the brace options. These are not meant to be substitutes, but simply add-ons that can help their patients right away. So those would be the, you know, sort of the take-home points.
Cool. I'll put those in the description here. And once again, I look forward to doing this again. Thank you so much, Ben.
Don, thank you so much. It was great finally being a guest on a great program.